Hi, my name is Aaron Gerds. I'm the editor-in-chief of ASH Clinical News. We're here in Orlando, Florida at the ASH annual meeting with our on-site coverage, and it's my absolute and utter pleasure to be joined today by Dr. Sidana, the chair of the Committee on Communications for ASH, as well as a world-renowned myeloma expert. Thank you so much for being with me today.
Thank you, Dr. Gerds.
All
it's
right.
a pleasure.
So we're going to talk about new and upcoming things, right? We have CAR-T cells, we have bispecifics, trispecifics, all this stuff that's brewing, but there's kind of a next wave of things coming for multiple myeloma, and there's this concept of hitting multiple targets at once. Can you explain about what is the role of dual targeting in multiple myeloma?
So for myeloma, the current approved CAR-Ts are against BCMA, or B-cell maturation antigen. And we have other targets in development like GPRC5D. Even CD19 was studied by itself in myeloma, and by itself wasn't very promising. But we know that sometimes when patients have progression, they escape by either antigen loss, antigen mutation, or antigen downregulation. So naturally, the concept is now to combine different targets to hit a higher efficacy threshold, not just in terms of response rates, but also in terms of durability, especially in the harder to treat patient population. And there's many concepts emerging about combining different targets. So this one abstract looked at BCMA and CD19. It's been evaluated in relapse setting, but this abstract looked at it in frontline setting, which is also what we are doing. Yeah, CAR-Ts were first studied in 5-6 prior lines of therapy, the absolute patients who had no other options. We then moved them to early relapse, and now we're moving them to first line therapy. And so this is an IIT coming out of China, combining two patient populations, transplant eligible, ineligible, where they looked at after VRD, so bortezomib, Lendex induction, they gave this CAR-T, which targets both CD19 and BCMA. Now, I will say this, that CD19 is not widely expressed in myeloma. And, there is a population of, experts in the field that feels that CD19 may be expressed in the myeloma stem cell, but I have to say, it's a very controversial topic. Like, people who believe in it really believe in it, and the others say, show me the evidence, we've never been able to find it. So that aside, I will say that, this CAR-T has shown very promising data in the relapse setting. And so it's not clear, though, to me, is it the BCMA that's very powerful? Is the CD19 doing something? And I'm not sure we'll be able to parse it out. But regardless, to say it's a very promising, very effective CAR-T. And what we found here was the response rates were like nearly 100%. MRD was 100% in the beginning. At 1 year was about 90%. I think, though, we need to look at durability. So for first line, it's not just about response, it's about durability. But if we can get that durability, that would be fantastic, because right now the paradigm in myeloma is you do induction, you may do a transplant, then you do maintenance forever. We need to shift from that to limited duration therapy, and CAR-T offers that attractiveness. Yes, you do a little bit of induction, you do CAR-T, maybe you do some consolidation, but after a few months or maybe a year or two, you stop. Because for the first time, we are now targeting cure in myeloma. Like 5 years ago, we couldn't even talk about cure in myeloma, but now with all of these new therapies, we're starting to say, how do we define cure? And the new International Myeloma Working Group guidelines are trying to come up with a definition of cure so we can test that in trials. Can we get to that? And I think all of these therapies are just so exciting. That's
incredibly exciting. I remember a time even further ago before all these things, and back in the Lendex days, and that was revolutionary, right? And so it's just amazing to see this field progress the way it is. And it's pretty remarkable to see CAR-T cells in the frontline setting too. I think it's amazing to see that development. It's really a testament to better efficacy, less toxicity, and implementation of such an amazing therapy. So this sounds like it's all in the early stages. What are kind of some of the next steps for development of this agent?
So for this agent in particular, this was an agent that was initially developed in China in the late relapse setting. AstraZeneca has now been developing it in the US, so there's trials ongoing. One of those trials was just presented yesterday at ASH. The follow-up is short, but the data look really good, and it's being now developed in frontline settings, so we'll see randomized trials coming up in the next year or so for both transplant ineligible and eligible population called the Durga-5 and Durga-6. So I think we'll be very excited to be enrolling patients on that. But this is the whole paradigm. We also have another trial of cilta-cel, which is the approved CAR-T in first relapse, called CARTITUDE-6.
Yeah.
It's a global trial looking at CAR-T versus transplant. So transplant stood its place for 40 years. I don't know what can displace it, but maybe it's CAR-T. So that trial is challenging transplant. But I think the balance will not just be in efficacy, but also with toxicity. With transplant, we see one kind of toxicity. With CAR-T, we see a different type of toxicity. And so I think that will be the balance with, who will have more second primary malignancies? Will there be delayed neurotoxicities, in patient tolerability? So I think all of those things we'll have to look at.
Oh, fantastic. Well, thank you for coming in today and sharing us your expertise and your perspectives on this rapidly developing field. So you can read about this abstract and all of our on-site coverage in ASH Clinical News.